go ahead and get started. So good morning, everybody. I did have a really important announcement that I needed to make, but hopefully it'll come to me. I'll just start by acknowledging that today's grand rounds are really new. Well, not a new initiative, but I guess an updated initiative to really highlight and showcase the latest advancements in research, particularly things that are happening locally, but also, nationally and internationally. So we are going to be doing these approximately quarterly. And we're hoping that this will really help to cultivate sort of collaboration across our departments and generate new ideas and so on. But before we begin, I would like to respectfully acknowledge that we are located on 26 territory, a traditional gathering place for diverse Indigenous peoples, including Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So with that, I am going to hand it over to our Director for Graduate Studies, who's covering for our Associate Chair Research, Evangelist Mikalakis. But I'm going to hand it over to Gopi Sutendra, who will introduce our speaker. Thanks.
Okay, thank you, Norman. Yes, I'm very excited to introduce our guest speaker today, Dr. John Usher. So actually, I've known John for about 20 years. And in fact, when we were doing our PhDs together, I was doing my PhD, of course, with Evangelos, and across the hallway was Gary Lopuschuk's lab, directly across the hallway. And that's where John Usher was doing his PhD at the same time. So we got to meet and became good friends at that time. So John actually, he did his undergraduate here in pharmacology, and then he went on to do his PhD in cardiac energy metabolism with Gary Lopuschuk, where he had a brilliant PhD and published a lot of good high novel papers on cardiac energy metabolism. And then he went on to Toronto, where he did his postdoctoral fellowship with Dr. Dan Drucker. And so for those of you who know who Dr. Drucker is, he's the one who came up with the GLP-1 receptor and the agonists. And, there's a lot of publicity with Ozempic and what it does for obesity. But he had a great training experience there with Dan Drucker. And I think next week, they're giving up the Nobel Prizes. So he very well may be getting it next week as well. After that, he was recruited back here at the University of Alberta in the Faculty of Pharmacy. And here he started his novel program looking at diabetes, but other things as well, and specifically diastolic dysfunction. And so this is an early index of heart failure. And so he really is looking at novel treatment strategies to deal with diastolic dysfunction to prevent potentially its progression to more severe diabetic cardiomyopathy. So with that, the last thing I want to say is I think John also is big into aging because he hasn't changed for 20 years. He still looks like he's in his early 20s. So really, just incredible work by John. He's CIHR funded. He has a CRC, Canada Research Chair, just been doing incredible work these last 10 to 15 years with his independent research program. So with that, thank you, John, and we look forward to hearing your talk.
All right, thank you, Dr. Sutendra, for the wonderful introduction. I'm really excited to be here today to present on some of my research and some of the clinical interests that I have. I know this is a very clinical audience, and so just thankful for the department for this opportunity. Maybe some of the things I talk about can lead to some really exciting collaborations. And so although Dr. Sutendra did kind of give you a little bit of background about myself, at least from what I was told, there's likely about 150 to 200 people online watching today's presentation. And I'm assuming the vast majority I've never interacted with. And so I thought I'd actually start, and even for some of my lab trainees are here, probably don't know so much about myself that I thought I'd start by just telling you about who I am. I'm a scientist, but I'm not just a scientist. And so I was actually born in the Philippines in Manila in 1982. But I didn't live there for a long time. So I don't have a lot of memories of Philippines because like 6 months into my birth, my family decided to immigrate to Canada. And so we moved to Edmonton, where I've lived the vast majority of my life. So this Edmonton has always been home for me. And while Dr. Sutendra made a little joke about how I look the same as when I was in my 20s, it's actually not the case. So I actually have this photo here. And so this is at my high school graduation. And I am the individual with blonde hair here. So that is me many, many years ago. But as he mentioned, I am an alum of the U of A. I did my undergraduate education and I got a bachelor's of science, specialized in pharmacology, did my PhD in pharmacology. And then in 2010, I was really fortunate to pursue a fellowship, as Dr. Sutendra mentioned, in Toronto with Dan Drucker, who in the 1980s is famous for identifying the biological actions of GLP-1, which is the active ingredient in many really important medicines for diabetes and obesity, such as Ozempic. And when I had trained as a postdoc there for 4.5 years, I had always reserved, kind of accepted the fact that I would probably have to start my lab somewhere that wasn't home. Just there are not many academic jobs out there. So I had applied to probably like 50 different universities. And so I feel very privileged and fortunate that in 2014, I was actually recruited and able to return to what is home for me, Edmonton, where I joined the University of Alberta at the Faculty of Pharmacy and Pharmaceutical Sciences to start my research lab, an independent program. And I know that we already did a land acknowledgement, but I'd also like to take the time to acknowledge that my lab at the U of A is located on Treaty 6 territory, and that we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And continuing with myself, again, I'm not just a scientist, so I just thought I'd tell you a few more interesting facts. If I could be anything other than a scientist, I'd love to explore and travel space, just like in Star Trek. And so unfortunately, I feel like I was probably born 200 years too early. And so hopefully maybe one day my great, 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 great grandchildren, I don't know if that's how many generations it would be, but maybe they'll get to live my dream one day. So maybe something a little bit more realistic in terms of being something else other than a scientist. I love sports. Me and Gopi, we debate sports all the time. Who's the greatest of all time in basketball, hockey? And to get paid millions of dollars to go on TV and give your hot take, that seems like the greatest job ever. So if I could be anything else, I'd love to debate sports on television. And then finally, just something on my bucket list, something that, if I can do before, the end of my time. I thought it would never be possible, still may not be possible. I didn't have time yesterday to try and get on the pre-sale, but I really want to attend an Oasis live concert with my wife. And just unfortunately, it was too hard yesterday. And I hear the prices are crazy, but I'm still hoping that maybe I can go to Toronto next year and see Oasis live with my wife. All right, but moving on to today's presentation. And so there are 3 major learning objectives that I want to discuss with all of you today. And I'm going to start with talking about the relevance of undiagnosed diastolic dysfunction in people with prediabetes or early stage type 2 diabetes. And this is directly relevant to something referred to as diabetic cardiomyopathy. And so I want to start by telling you, what is diabetic cardiomyopathy? And so this phenotype or this pathology was first identified by Shirley Rubler and colleagues in 1972, where they looked at autopsy findings in 4 individuals with diabetes, where they observed cardiomegaly and congestive heart failure of no known cause, and in the absence of coronary artery disease. And so based on this original report in 1972, kind of the classic canonical definition that you will often see in textbooks, in review papers on diabetic cardiomyopathy, is that it is ventricular dysfunction with diabetes, but without coronary artery disease and or hypertension. And so when I approached my mentor, Gary Lopez-Chuck, when I came back to the U of A about my program, and I told him that I wanted to focus a lot on diabetic cardiomyopathy, he kind of told me, you know, in the most polite way possible, that he didn't think it was a worthwhile idea. Not many people have diabetic cardiomyopathy. And when I talked to others, many people shared that sentiment that diabetic cardiomyopathy is not really that prevalent of a thing. And I think part of the issue with that is because so much of it stems from this specific definition. And the reality is, over the last 20, 25 years, the field has learned so much more, both in preclinical and clinical studies, as to what diabetic cardiomyopathy is, like what defines it, what its unique features are. But we haven't really updated the definition. And I feel like the definition probably should be redefined. But also part of the issue is in terms of like, how do we diagnose diabetic cardiomyopathy? You know, what characterizes its pathology in the early stages of type 2 diabetes if it's present? And so part of the issue here, so when I talk to my clinical colleagues, many of them, you know, will share with me that, you know, like when someone is newly diagnosed with diabetes or type 2 diabetes, the focus of clinical management is not, let's send you to the imaging clinic and get your cardiac function, you know, assessed, but let's lower your blood sugar. Let's see if we can do lifestyle interventions to help with your elevated blood sugar, to help with likely with type 2 diabetes, often accompanied by living with overweight or obesity. Can we help with weight loss? So those are the initial focus. But what is, you know, in the studies that have explored this, and depending on the criteria that is used, that some estimates say, it's a very wide range, but estimates say that, you know, from as low as 20 to as high as maybe even 80% of individuals in the early stages of type 2 diabetes will have some form of diastolic dysfunction present. And it's actually this diastolic dysfunction, which is really a key pathological feature of what is diabetic cardiomyopathy. And I think what should be built into the new definition of diabetic cardiomyopathy. And this is relevant as, you know, one of my last objectives today with you all is to talk about how are there links if someone has diabetic cardiomyopathy and diastolic dysfunction, which is, you know, a failure of the heart to properly relax between contraction. Does this actually evolve into heart failure with preserved ejection fraction, as that is also characterized by diastolic dysfunction? And there's even some suggestion, at least for us basic scientists, we often view these as like sequential progressive disease, where over time this will lead to HFrEF, heart failure with reduced ejection fraction. Though my clinical colleagues, when I talk to them about, you know, the research that I do and my interests, you know, are often also quick to tell me that the situation is much more complicated than that. So, you know, we like to think it's sequential, like us basic scientists, that, you know, when you have prediabetes and insulin resistance, you have oxidative stress, inflammation, that then leads to diastolic dysfunction, eventually systolic dysfunction, heart failure, and then cardiovascular death. It's nice, you know, you can make these nice little like chronological graphs, tables. But again, there are, as my clinical colleagues tell me, there are over 400 million people with diabetes. And so there are just so many, it's such a heterogeneous disease that there are actually different phenotypes. And so some will be sequential and progressive, yes, but some will ever only have diastolic dysfunction. Some will actually have systolic dysfunction and no sign of diastolic dysfunction. And some are going to have elements of both. But one of the things I want to highlight here in this slide, because one of my last objectives is talking about for those where it may be sequential, where they start with diastolic dysfunction, diabetic cardiomyopathy, and over time maybe develop HFpEF, is that like, because some people now will, you know, from basic science side will view like, is diabetic cardiomyopathy just HFpEF in someone with diabetes? There are some clear distinctions. So, you know, someone with, one of the main ones really is this exertional dyspnea and exercise intolerance. So someone with HFpEF, they walk up a flight of stairs and they have breathlessness. That's not the same for someone, you know, with early stage type 2 diabetes and diabetic cardiomyopathy. So there are like, they are very likely distinct clinical entities. It's not just HFpEF in someone with diabetes. But I do believe that for a significant portion of individuals with type 2 diabetes, that it can be sequential and progressive, where having diabetic cardiomyopathy will be a precursor to developing HFpEF later in life. And so now I'll take you just through some of the clinical data supporting that there is diastolic dysfunction in type 2 diabetes. And so while cardiac MRI is the gold standard to measure and assess diastolic function in humans, it's not as readily available as ultrasound echocardiography. And there have been numerous advancements in using echo to quantify diastolic function. And so some of the most common parameters we can use pulse wave Doppler, and we look at what is known as the E to A ratio. So the E wave is the early phase of diastole. And so that's really driven by the pressure gradient driving blood flow from the left atria to the left ventricle during the early phase of diastole. Whereas the A ratio, the A part of the equation, the A wave, that's the late phase of diastole. So that's when the actual atria contracts to contribute to the remaining blood flow from left atria to left ventricle. And so this ratio decreases in someone with diastolic dysfunction. Correspondingly, you can also use tissue Doppler and look at the E prime to A prime ratio. So these are essentially the same parameters during the early and late phase of diastole, but now measuring the tissue velocity as opposed to the blood flow velocity. And this ratio also decreases in someone with diastolic dysfunction. And you could also look at the two together, and an increase in the E to E prime ratio is reflective of diastolic dysfunction. And so at least here, a clinical study looking at 300 individuals with diabetes. You also have atrial remodeling. And so these individuals were segregated based on left atrial volume. And you can see those with the bigger left atrial volumes had evidence of diastolic dysfunction as seen by the decrease in the E to A ratio and an increase in the E to E prime ratio. In a smaller study of individuals with type 2 diabetes, again, looking at the same parameters, you see those with type 2 diabetes had a decrease in the E to A ratio and had an increase in the E to E prime ratio, indicating diastolic dysfunction being present in these individuals. And so again, my lab is a preclinical, basic science lab. And so we can actually see this in our preclinical models of type 2 diabetes. So this is some just a study from a mouse with type 2 diabetes. And you can see primarily driven by an increase in the A wave velocity that you have a lowering of the E to A ratio. And so now I want to spend some time just taking you through the model we use preclinically to kind of model this diastolic dysfunction and diabetic cardiomyopathy phenotype. And so we use this model where we combined a high-fat diet or a high-fat, high-sucrose diet in mice to give them overnutrition, and usually between 8 to 12 weeks, they'll experience significant weight gain and obesity, usually about 50 to maybe 75% weight gain versus a mouse that is on a standard chow diet. And we combine it with a beta cell toxin known as streptozotocin. And so STZ is a beta cell toxin that at high doses is actually used experimentally to destroy the islet beta cells and cause type 1 diabetes. So we use a low dose that only eliminates vulnerable beta cells. So they are still hyperinsulinemic from the remaining beta cells. And so this nicely models like it's a preclinical model of type 2 diabetes. It's the model we like to use. Though when I submit grants, to Diabetes Canada or the CIHR, and when I submit them to a diabetes audience, I will often get heavily criticized. Why? Like a lot of people don't like this beta cell toxin, streptozotocin. And so often the comment I will get is, why not just give them the high-fat diet that makes them insulin resistant, pre-diabetic? It's much more translationally relevant. I'm not going to argue with that. Like I think the dietary approach is better. But the biggest concern is, at least from my perspective, and why we need to use this streptozotocin is, so I've been using high-fat diets in mice for 20 years now. And I have never seen a high-fat diet consistently cause real cardiac dysfunction in mice. Many of my colleagues have seen the exact same thing. You'll read some papers in the literature, people will see some really robust phenotypes. I have never seen it. Many of my colleagues have never seen it. And the reason why we are very adamant that you need to use this low-dose streptozotocin is it allows us to get this very consistent and reproducible diastolic dysfunction which I believe is reflective of people with early stage type 2 diabetes that have diastolic dysfunction. I think it's a very important aspect of the model. And so we have to do it this way. And just to give you an example of this, you can see here. So if I just feed mice a high-fat diet, you can see the E prime to A prime ratio is similar to lean mice. The E to A ratio is similar to lean mice. But once we add the STZ component, you now see the decrease in the E prime to A prime ratio. You see the decrease in the E to A ratio. And not depicted here, you see the elevation in the E to E prime ratio. And also just, as an aside, I'm very fond of this model because, it's the grad students in the lab that do all this work. This is a model that's like 12 to 18 weeks at most. And, some people argue, like even though we've never really seen it still, people will argue if you just put them on a high-fat diet for a year, then maybe you'll see that diastolic dysfunction. And so, when I think about the livelihood and health of my grad students, I like to refer to our model is the work-life balance model. 12 to 18 weeks, if reviewers want us to repeat a study, easy for me to talk to a trainee and say, let's repeat the study and let's get more tissue so we can look at this to satisfy the reviewer. If I ask that grad student, so a number of them are in the lab here, if I said to them, let's do a year study to answer this question, I think many would be a little unhappy with me. So at least for us, we personally enjoy this model very much. All right, so now I want to move on to the second objective today. And so I want to talk about novel targets for potentially alleviating this diastolic dysfunction in people living with early stage type 2 diabetes. And I'm really going to focus on optimizing energy metabolism in the heart, which is my area of expertise. But again, as I mentioned at the beginning, over the last 20 years, the field has learned so much more about the potential pathology of diabetic cardiomyopathy. And so there are so many proposed mechanisms. Everyone's favorite mechanism, like inflammation, endoplasmic reticulum stress, extracellular matrix remodeling, dyslipidemia, all proposed to have some component that contributes to diabetic cardiomyopathy and its diastolic dysfunction. But again, for what we're going to focus on, it's going to be alterations in energy metabolism. And so I can spend a lecture, 2 lectures, talking about all the metabolic changes in the heart. It's something I'm very, enthusiastic about. But I've really simplified it for you here in this little cartoon that so many studies preclinically and also clinically have shown that in models or humans with obesity or type 2 diabetes, that the heart derives the majority of its energy to support its pump function by burning fat as its major fuel source to produce its energy, and it has a robust impairment in its ability to burn carbohydrate sugars to make energy to support its pump function. And so again, I could go over a whole bunch of preclinical to support this, but I thought I'd just highlight a couple of clinical studies, since we're talking with the Department of Medicine to highlight what the clinical studies have shown. Now, there's been less because there's not as many tools available versus what we have at a basic science level, in an ex vivo or in vitro model system. But you can see here some nice work by Linda Peterson at Washington University using positron emission tomography imaging, where she took either non-obese or obese insulin-resistant pre-diabetic women. And so there's a specific radioisotope with PET imaging where you can actually quantify fat oxidation in the heart. And what she observed was that fat oxidation rates were elevated in the hearts of the obese pre-diabetic women. And the worse glucose control they had, the worse insulin resistance, you had this positive correlation with further increases in fatty acid oxidation rates in the heart. Now, one of the other weaknesses, at least in the clinical field, for studying these energy metabolism alterations is until very recently, there actually hasn't been a good tracer, a good radioisotope to measure glucose oxidation in humans non-invasively. That's changed recently in the last 5 years. Kim Connolly at St. Michael's Hospital in Toronto, as well as Oliver Ryder in Oxford, they've really been kind of pioneering using hyperpolarized carbon-13 isotopes with MRS, magnetic resonance spectroscopy, as a tool to assess glucose oxidation. And so you can actually use a carbon-13 glucose with a hyperpolarized MRS system. and measure glucose oxidation non-invasively in humans. So this is a really exciting development. And you can see in a healthy individual, in the fasted state, the blue bar, where you have low insulin levels, insulin promotes glucose metabolism, so your glucose oxidation is low. And then when these individuals are fed and insulin is secreted to stimulate glucose metabolism, you have an elevation in glucose oxidation in the heart. Conversely, someone with type 2 diabetes, you can see that even though they still respond when they eat a meal, you can see that their glucose oxidation either in the fed state or the fasted state is markedly lowered versus the healthy participant that they were compared to. So again, kind of just matching what I showed you in the cartoon, that the heart and diabetes, low glucose oxidation rates, high fatty acid oxidation rates. And so now I want to talk about and transition to some of the research in our lab dealing with how a current clinical therapy might actually be able to reverse this metabolic profile in the heart of someone with type 2 diabetes and have positive actions on diastolic dysfunction. And so as already mentioned, we talked a little bit, I trained with Dan Drucker, where I studied the cardiovascular, all right, let's, not certain what happened there, but let's go back to this, and we will, all right, just give me no worries. I'm sure everyone wants to see my blonde hair again. All right, we are almost there. All right, apologize for the little mishap there. But yeah, so I trained with Dan Drucker to study the cardiovascular actions of GLP-1 based medicines. And so that's what I'm going to talk about now in terms of like this current therapy, I think might have a role in managing this diastolic dysfunction. And so there are two types of GLP-1 based therapies. They're the DPP-4 inhibitors, that they prevent the degradation of endogenously secreted GLP-1 in response to a meal. And then we actually have the long-acting agonists that aren't degraded, like Ozempic, semaglutide. I mean, both for most part have been kind of effective for lowering blood sugar levels. At least traditionally, people have preferred the DPP-4 inhibitors because they're pills versus being injectables. Things are changing, though, quite rapidly over the last 5 years, just because while they may have equivalent glucose lowering, the DPP-4 inhibitors don't lower body weight. They don't improve cardiovascular outcomes like a GLP-1 receptor agonist does. And so here's just a little summary. So there have been now actually, so this table is a little out of date. I believe there have been now 8 or 9 large-scale phase 3 cardiovascular outcomes trials that have looked at the actions of these GLP-1 receptor agonists on cardiovascular outcomes in people with type 2 diabetes. And so it's been a really exciting time for the incretin field. Liraglutide in the LEADER trial, semaglutide in the SUSTAIN-6 trial, albiglutide in the Harmony Outcomes trial, dulaglutide in the REWIND trial, all showed that these specific GLP-1 receptor agonists improve cardiovascular outcomes. So, time, either being time to cardiovascular death or non-fatal MI, non-fatal stroke, hospitalization for heart failure, that all these events or a combination of these events were improved in people taking these medicines. And they've not all been positive. So you can see here on the left, both exenatide and lixisenatide and Excel and Elixa were actually neutral. So they didn't make things worse, they didn't make things better. It was argued that maybe the reason that these two drugs were negative or were neutral and not positive is that they are not strictly GLP-1 based medicines, they're exendin-4 based medicines. So exendin-4 is a lizard homologue of the GLP-1 peptide, has about a 53% homology, acts very similarly to promote insulin secretion. It was argued because they're exendin-4 based that maybe that's why they failed. I think the reality, it's probably more likely that these drugs have shorter half-lives. They don't engage the GLP-1 receptor as robustly because more recently, not on this table, F-peglinetide is a long-acting exendin-4 analog, and that was shown in its cardiovascular outcomes trial to highly improve cardiovascular outcomes in people with type 2 diabetes. But again, just to kind of briefly highlight how these drugs are supposed to work and why I think they can reverse the metabolic profile of the heart in type 2 diabetes is these are insulin secretagogues. So either the endogenously released GLP-1, or if you give someone a GLP-1 receptor agonist, they act on the islet beta cells or in the pancreas, and they increase insulin secretion. And insulin, as I've stated, is a potent stimulator of glucose metabolism in the body. At the same time, they also decrease glucagon secretion, and glucagon increases fat utilization in the heart and other organs. So just by modifying that hormonal environment, their biological actions, we might be able to reverse this cardiac metabolic phenotype in obesity or type 2 diabetes. There's also the possibility that these agents could have direct actions on the heart, though I would argue is unlikely to be direct actions. And part of the reason for that, for me making that statement, is at least when I was a postdoc in Dan Drucker's lab, the postdoc I shared an office with, Dr. Min-Suk Kim, had performed a study showing, so this is a southern blot. All you really need to know is the black bands here are the full-length receptor in a myocyte, in a cardiac myocyte. And you can see that while atrial cardiac myocytes express the receptor, they're actually, the ventricular myocyte, which is the primary cell type that burns, makes the heart the most oxidative organ, energy demanding organ on a per gram basis in the body, that receptor isn't there. So I think it's more likely an indirect action versus being a direct action. And so now to kind of show you some of the research in our lab in this area to kind of prove whether this might be actually happening, we had a really simple objective. And our hypothesis was simple because insulin is a potent stimulator of glucose metabolism. We hypothesized that a GLP-1 receptor agonist, and part of its mechanism of cardioprotection possibly, is because it increases glucose oxidation and optimizes that profile that I shared with you earlier. And so we also hypothesized that these actions would actually be beneficial for the diastolic dysfunction present in type 2 diabetes, diabetic cardiomyopathy. So some simple experiments that we did in the lab, this was work by a former master's student, Malak Al-Matairi. We actually isolated hearts from mice, and we just directly treated them with a GLP-1 receptor agonist. And so we used liraglutide at the time. And what we observed, so the green bars here are the liraglutide-treated hearts. And so glucose metabolism is comprised of glycolysis and its oxidation. And you can see actually liraglutide had no effect. This is consistent with the fact that there, as I just showed you, the receptor is not present in ventricular cardiac myocytes. So we did a different experiment. We actually treated the mouse first with the drug so that the GLP-1 receptor agonist could promote that insulin secretion. And, that insulin could activate its signaling in the heart to increase glucose metabolism. And then we isolated the heart and measured its glucose metabolism. And when we did that, while we didn't see an increase in glycolysis, so the blue bar now is the liraglutide-treated animals, we saw a doubling in the oxidation of glucose. And importantly, this action was preserved in type 2 diabetes. So this was a lean mouse. When we took a mouse with our model of type 2 diabetes, while the rates are lower than in a lean, healthy mouse, we're still able to double the glucose oxidation rates. And so now I don't want to bore you with metabolic pathways, but I just want to highlight one pathway because it's going to become relevant to how we link this mechanism to how these drugs may work. But in order to actually oxidize and generate ATP energy from glucose, that glucose through glycolysis has to get converted to pyruvate. That pyruvate has to get into the mitochondria. And this one singular enzyme here, PDH, pyruvate dehydrogenase, is what oxidizes the glucose and allows us to make energy from it. And so when we looked at the activity of PDH, so these are bands for the phosphorylated form of the protein. And the less phosphorylated it is, the more active it is, and the higher glucose oxidation is. And so you can see that liraglutide decreased the phosphorylation of PDH, indicating that its activity is higher and the glucose oxidation rate is higher. And when we actually looked at cardiac function, when we did a long-term study, chronic treatment with these drugs in mice with type 2 diabetes, so the left graphs here are systolic function, ejection fraction, fractional shortening. Our model of diabetic cardiomyopathy has really minor, mild, or no systolic dysfunction. So we didn't really observe anything here because there's no dysfunction. But when we looked at parameters of diastolic function, you can see that liraglutide increased the E to A ratio and prevented the elevation in the E to E prime ratio, both suggestive of an improvement in diastolic function. And so we believe the increase in glucose oxidation contributes to this phenotype. But this is just association, it's not cause and effect. So if we go back to this figure here, how did we choose to try and prove that the increase in glucose oxidation explains how liraglutide or a GLP-1 receptor agonist alleviates diastolic dysfunction in type 2 diabetes? So one of the things that my lab frequently uses, we are, like when I train with Dan Drucker, I spend a lot of time learning how to use tissue-specific gene knockout mouse models. And so we actually, this enzyme I told you about, PDH, the singular enzyme required to oxidize glucose, we actually selectively removed it only in the hearts of mice. And then we put these animals on our model of type 2 diabetes. We've confirmed, I'm not going to go through the data, but these hearts cannot oxidize glucose whatsoever. And we repeated our study and treated these animals, or treated these animals with liraglutide or control. So the animals that can oxidize glucose, that don't have PDH, are the blue bars. And when we look at systolic function, again, there's no systolic dysfunction in our model. You can see either in the normal mice, the red bars, or the genetic model, liraglutide isn't doing anything to stroke volume, ejection fraction. But importantly, when we look at parameters now of diastolic function, as expected in the red bar, the normal mouse that can oxidize glucose, where liraglutide can increase the oxidation of glucose, we elevate the E prime to A prime ratio. We lower the E to E prime ratio. But the blue bars, the heart-specific PDH knockout mice, that does not happen. So liraglutide can increase glucose oxidation. It can improve that diastolic dysfunction. And also, just to clarify, this work is from my current PhD student, Jordan Chan. He's in the audience, so I just want to make sure I give him that shout out. But importantly, the liraglutide could still improve glucose homeostasis. Your blood sugar control is equivalently lowered with liraglutide treatment. So it's still doing its anti-diabetic actions, but it can't lower, or it can't improve the diastolic function because it can't increase the glucose oxidation. So I think that this is potentially an important mechanism of how these drugs may benefit cardiovascular outcomes, or at least specifically this diastolic dysfunction in diabetic cardiomyopathy. So with that being said, I now want to kind of transition into kind of the final objective of my presentation today, some of the areas that I'm really interested in, and ideally, if anyone has interest in the audience, like potential for, possibly collaborations, if anyone has an appetite for it. But will early management of diastolic dysfunction in people with type 2 diabetes impact the progression of heart failure with preserved ejection fraction, which I mentioned is characterized by diastolic dysfunction. It's actually the form of heart failure that is now more prevalent in people living with type 2 diabetes. But before I get to that, I want to revisit this table here. And so I showed you these exciting cardiovascular outcomes with GLP-1 receptor agonists. And again, we think our mechanism with the glucose oxidation might contribute possibly to this. But there are some important things that we have to take in consideration, and as I transition to this last objective of mine. And so first, I want to take a closer look at SUSTAIN-6. So this is the semaglutide cardiovascular outcomes trial. And what I really want to highlight here is that you can see that the mean age of participant in this trial is about 65 years of age across all groups. And when we look at their history of cardiovascular disease, also, high-risk population, 60% in most groups had ischemic heart disease, about a third had already had a myocardial infarction, heart attack, and almost a quarter were living with heart failure. Now let's take a look at REWIND, the dulaglutide cardiovascular outcome trial. You can once again see the mean age of participants, 66 years now as opposed to 65. And another I want to highlight there, you can see that so the cardiovascular disease, less cardiovascular risk, 30% population. But the other thing I want to highlight is that you can see the average duration of diabetes in a participant in this trial is about 10 years of having type 2 diabetes. Now, finally, one last trial I want to take a look at. This is not a type 2 diabetes cardiovascular outcomes trial. It's the SELECT trial, actually the obesity vascular outcomes trial. So these are people living with obesity, but not type 2 diabetes. It's also semaglutide phase 3 cardiovascular outcomes trial. But again, just want to highlight that you see here about 60, the mean age of participant, a little over 60 years of age. And so the point that I want to make here in relation to the mechanism that I'm talking about with our research is that what we study in our preclinical model is not reflective of the individuals that are in these CVOTs. Patients in cardiovascular outcomes trials are older, at greater cardiovascular risk, and have had type 2 diabetes for a much longer duration than what is in our model. But the point I want to highlight now, when I get to this last objective that I think is really important, that I'm really interested in, again, if there are people who have interest in pursuing this, is I still think even though our model doesn't reflect the population in a CVOT, I believe the populations in the CVOT are ignoring a really important population. Many people, again, there are over 400 million people living with diabetes. Estimates are by 2050 that number, I think, is going to be over 700 million. Many people are actually now diagnosed with type 2 diabetes in their 40s, 50s. A recent study I read, a population study in the States from 2011 to 2018, that the mean age of diagnosis of type 2 diabetes was 49.9 years of age. And importantly, those who are diagnosed with type 2 diabetes at a younger age are actually at worsened risk of cardiovascular disease in the future. So like if you had type 2 diabetes diagnosis at 45, when you're 65, your risk for cardiovascular disease is going to be greater than someone who is diagnosed with type 2 diabetes at 60 when they reach 65. And so this is then like the questions that I believe are potentially important to answer, and where maybe our research is worth seeing if it does translate, is for someone who is actually diagnosed with type 2 diabetes in their 40s or 50s, do they have diastolic dysfunction? And in relation to the research that I've shared with you, again, early management often is going to be, let's get you on lifestyle interventions like diet, exercise. Many people won't respond to that. Often a first therapeutic choice is going to be metformin. About 15–20% of individuals, due to the GI upset or other reasons, might also not be able to take metformin. And with practice guidelines starting to change now with all the evidence we have with GLP-1 receptor agonists that have benefits on cardiovascular outcomes, that cause weight loss, that these individuals might be considered now for GLP-1 receptor agonist treatment. And the question is, for someone who's newly diagnosed with type 2 diabetes in their 40s or 50s, who takes this therapy, does taking that therapy actually improve their diastolic function? Does it increase their glucose oxidation in the heart? And again, none of these studies have actually been pursued, but I think there's opportunity now with the things available to us that we could pursue these studies and see if some of this stuff does translate. And very importantly, in relation to my last objective, because diastolic dysfunction is also a defining feature of heart failure with preserved ejection fraction, for someone who has diastolic dysfunction and type 2 diabetes in their 40s, 50s, if we actively manage it then and now, like right away, when that individual is in their 60s or 70s, will that individual develop HFpEF? Are they less likely? And so at least, from what I'm aware of, I don't think anyone has done those studies. I imagine these are probably not easy studies to do in terms of the time of length, but I think it'd be really cool, to pursue these studies and see what the outcomes would actually be. And so finally, to summarize and conclude everything that I've shared with you over these last 45 minutes. So I hope I've kind of driven home the point that people with type 2 diabetes often have underlying but undiagnosed diastolic dysfunction, which is a key characteristic of what I believe should be a redefined pathology of diabetic cardiomyopathy. There are many proposed targets that seem to contribute to this phenotype, this diabetic cardiomyopathy. But the one that I'm really interested in, and I believe could be a novel target, is correcting the impaired glucose oxidation rates in the hearts. And this might be achievable with the medicine we already have, the GLP-1 receptor agonists. And finally, as I just stated, that I think it might be worthwhile to consider whether we should actually screen for diastolic function in people with early stage type 2 diabetes and proactively treat it. And maybe that might have potential impact on the future prevalence of HFpEF. And so finally, to end, just want to acknowledge those involved. And so as I mentioned, at least the research from my lab that I shared, first part of it was led by master's student Malak Al-Matayri, whereas the more recent work with the PDH genetic knockout model was done by a PhD student Jordan Chan. Also, everyone in the lab, many people contribute to these studies. Also very grateful to the many collaborators I have and the several funding agencies that have supported the work. So I'd like to thank you for your time and attention, and happy to try to answer any questions that you may have. Thank you.
Thank you, John. So we're open for questions.
Yes.
So, yeah.
You illustrated a single intervention in what is clearly a multi-etiological problem. If I draw parallels from where I work, which is below the diaphragm in another hollow viscus affected by diabetes, the alterations in matrix seem to outweigh the effects on myocyte metabolism and contractility. So is there a dominant mechanism, and is the change in metabolism in the myocyte going to make any difference when you're contracting within a stiff matrix, which impairs relaxation?
Yes. So we haven't looked at matrix specifically. So, very important, interesting question. We see that, and everyone likes to think that their mechanism is the most important one. The reality, I think, is that all of there's not one singular thing that predominates, and it's likely, a combined interaction of all the things, like all the pathology that's going on. So it's the extracellular matrix dysfunction, the fibrosis, the alterations of metabolism, impaired calcium handling, oxidative stress, all have a component that matters. What I can say is that some of the studies that we've done, we've seen if you actually improve the metabolism, that some of the fibrosis actually gets better. But our model that we use, it's a very mild fibrosis. So it's not a severe fibrosis where you have like more severe, part of that, like with HFpEF, we'd have like a lot more of that fibrosis. Our model is very mild. So I don't know in a more severe model if that would actually change, but at least in ours where it's mild, I haven't looked at the matrix so much excessively, but we've seen a little bit of a reduction in the fibrosis.
So John, I'll ask a question while maybe we get some more from the chat. Narman noticed, and I noticed as well, in one of the trials, it was 72% male.
Yes.
Were in it. So do you see any sex differences both with the GLP-1 agonists in the literature or in your models, and overall any sex differences with any of the metabolic parameters you?
Yeah, so I guess first thing, it's really unfortunate the vast majority of these cardiovascular outcomes trials have been about 70% male. There was, I believe Rewind with dulaglutide was actually more close to a 50-50 split. And that one was also, showed benefit. But very important to see if there may be sex-specific differences with these agents. So at least in relation to your question, have we seen any differences? We've started to do also some studies in female mice looking at the energy metabolism. One of the big issues, unfortunately, is female mice are quite resistant weight with the high-fat diet versus their male counterparts. We don't actually see much diastolic dysfunction when we use the model in female mice. What we've done recently in collaboration with Dr. Sandra Davich in the last year is we've actually started combining ovariectomy surgeries so we actually eliminate the estrogen component. So it's more now a model of like because diabetic cardiomyopathy is actually more prevalent in postmenopausal versus premenopausal women. When we do that, we can actually make the phenotype almost perfectly copy what we see in male mice, but we haven't seen if the GLP-1s can then reverse and make things better in that model. So, but we don't have a good model because premenopausal women are also at risk of diabetic cardiomyopathy. And so right now we don't have a model where we can kind of really study that. And we just kind of have now this optimization that we've made that allows us to study more postmenopausal diabetes. So it's really important. And I think it's important that, more of us basic scientists, because a lot of us don't study female mice, and we need to figure out if our models are actually relevant, to the female sex. And so that is something that we're starting to pursue a little bit more aggressively.
So your very beginning, you defined diabetic cardiomyopathy as cardiomyopathy and diabetes in the absence of hypertension and ischemic heart disease, and then 60% of the patients in the GLP-1 heart failure trials, therefore by definition, did not have diabetic cardiomyopathy. Is that a problem? And were there any subgroup analyses done of the isolated diabetic cardiomyopathy punters in there?
I don't think it's necessarily a problem because I think that I didn't go through all the, actually this oxidation mechanism has actually been shown to also be beneficial for just ischemic heart disease, myocardial infarction, HFrEF. So I think, and these drugs clearly seem to have a benefit for some of these things. I guess the point that I was trying to highlight a bit more is that I think that we, at least someone with early, because again, in these trials, these people are 60, 70 years old, most of them have had diabetes 10 years or longer, where what we're studying, is not the same population. I'd argue that I think both are important. And I just think that, I don't want to say that the population of CVOT is important because it's clearly very important. But I also think that there are a whole bunch of people that are younger that have this disease that are likely, living with overweight, obesity, that just with what these drugs are showing. And because there are better ones, Monojuro is coming out, there's triple agonists coming out, that you're probably going to see a lot more people early on, in their 40s, 50s, start taking these drugs for their obesity and their type 2 diabetes. And if they actually do improve this diastolic function, I think we have to start studying those just as aggressively and seeing, if you take these medicines for 20 years and you treat that diastolic dysfunction, is that going to be beneficial, when you're 70 and at other risk of cardiovascular diseases? Or is it maybe even going to be harmful? If you take these drugs, we don't know the answer to that, but I think important that we start thinking about these studies.
Can I just, so first of all, Justin just online has indicated the STEPH HFpEF study was 50% female, male, and there were equal effects on biomarkers and FCUS. So just, but just to your point, well, first of all, just give you some clinical relevance. It's not, I'm a general internist, and it's really remarkable anecdotally where we will see obese patients without diabetes who have remarkably preserved heart function, diastolic function, and so on. So what you're seeing in the lab, I mean, anecdotally speaking, I can tell you, I can confirm in the clinical realm, even though you would think with that level of stress on the heart, that they would over time develop. So there definitely is that glucose oxidation piece that's missing. But just going back to your point about female mice, and I don't know enough in the basic science realm to know whether female mice would be equivalent to female humans. But what about the ones where you do treat with streptozin and, sort of cause the diabetic effects that you talked about earlier? Have you seen a difference with those?
So even with the female mice actually are resistant to both the diet and the weight gain and the streptozotocin component. So essentially, I guess it would have been nice if I showed the data, but visually, their glucose intolerance, their body weight gain, all those metabolic features, they change a little bit.
Yeah.
And if we ovariectomize them, then all those graphs superimpose with what a male mouse on the model looks like. So the females are just really from all aspects are, and it's one thing because no one reports on there's very few studies in female mice on this model in the literature. So we spent a lot of time. We even we rather than do 12 weeks, we went 24 weeks. We're oh, maybe if we go longer. And for most part, we've never seen the model cause have it look like a male where there's some dysfunction to study. And we can really only get it if we add this ovariectomy, which, I've been critiqued on a recent grant that this is not really relevant to the premenopause. But I'm I don't know how to make it work in the premenopausal. It's we're trying to, we're optimizing. We've even played with higher doses of STZ. So, I mean, still important. We're trying to find a way to optimize it, but at least right now, it feels like this is the only way we can kind of get it to kind of be a little bit more similar to what we see in male mice, where we can try an intervention and see if an intervention can actually fix things or make the pathology better.
That darned protective estrogen.
Yeah.
There's nothing online. Oh, sure.
This thing is very intimidating. So I guess, I don't know if this is an answerable question or it's going to open a huge can of worms, but what about SGLT2 inhibitors?
Yeah, so I guess, I don't remember which, I mean, because SGLT2 inhibitors have also been shown to be, very cardioprotective,
Absolutely.
very different mechanism of action. I mean, might be opportunity for, adjunct combination therapy with the two. I don't know how often that is pursued. What I do know from one of the CVOTs, I don't know if it might have been Rewind, or it might have been the peglanitide one that I didn't show. But one of them actually had I think it was 30 to 40% of individuals on an SGLT2 inhibitor as well on the trial. And in that CVOT, regardless if you had a SGLT2 or not, the GLP-1 receptor agonist was still, when you subgrouped them, it was equivalently improving cardiovascular outcomes. So I think even though SGLT2s are I think it's an exciting thing where there's more options, to endocrinologists or a physician to prescribe to their person with diabetes that they're helping manage. Yeah, so I like the data from that one trial has suggested that even if you're on an SGLT2, adding a GLP-1 can still confer additional improvement in cardiovascular outcomes. I think it's a really important question in terms of because I don't think there's actually been many head-to-head comparisons in terms of which one is actually better. And I think that will also really come down to in terms of injectable versus pill, though there are oral GLP-1s being developed now, which is also really exciting. But I would say just because the GLP-1s also have the really robust weight loss actions, and many people with type 2 diabetes are also living with obesity or overweight, that a lot of those will come into factor in terms of which you should be prescribing. At least I think. But I don't want to, I'm not a clinician, so I don't want to comment on those things. So, but I think really important questions and really, it's a really exciting time for people in this field.
Oh, actually, this was a variation on Ross's question. I'm Darren Lau. I'm one of the general internists as well. And I think we've corresponded recently about a peer review. Thank you so much for that. That was quite helpful. But anyways, SGLT2 inhibitors, I'm curious because they, the mechanism of benefit for heart failure isn't just hemodynamic related to volume status, but there's been a lot of literature about how it predisposes to more ketone-based metabolism and actually reduces fibrosis. And I'm wondering from a basic science perspective, do you expect there to be similar mechanisms at play for SGLT2 inhibitors, which have more data for diastolic heart failure benefit in the clinical setting?
No, thank you for your fantastic question. So at least in terms of whether there might be because you mentioned the ketones. So I haven't studied that myself, but actually, so my former PhD mentor, Gary Lopez-Chuck, both him and Jason Dyke in the Department of Pediatrics here have done a lot of work with the SGLT2 inhibitors and their metabolic actions. They don't have the same actions on glucose oxidation like a GLP-1 receptor agonist, and they don't actually see major increases in ketone oxidation, which had been initially proposed. They do see increases in ketones, and so one of the interesting things here, so a lot of that SGLT2 and its metabolic benefit, being attributed to the ketones and metabolism, has started to shift more to, because ketones are not just fuel, they're also really powerful signaling molecules. And so people are starting to kind of shift that. It's more that you have increases in ketones with an SGLT2, and that has really increases in ketones have very powerful anti-inflammatory signaling actions. And so there's been a little bit of a shift that maybe it's more the ketone decreasing inflammation versus ketone being a fuel for the heart. Is where some of that started to shift. But very important. And that's why I'd say too, because they have different mechanisms. I think that the potential for adjunct combination with those two is potentially there.
Okay, with that, thank you, John, for a very stimulating talk and discussion afterwards.
Thank you for having me.
Is that everything? Yep, perfect. Thank you.